Welcome, everyone. As you're aware, research on ALS is continuously progressing. At Everything ALS, we are dedicated to uncovering new discoveries, aiding in early detection, and working towards finding a cure for ALS. You can assist us by participating in our speech study. The purpose of the speech study is to enhance the diagnosis and prognosis of ALS. We are seeking participants to provide 5 speech recordings, each lasting 15 minutes once a month over 5 months. Pretty easy to complete. We welcome healthy participants as well as individuals diagnosed or probable with ALS to join us. To enroll, please visit everythingals.org/speech project and fill out our form. Thank you, and you will find the email address posted in the chat. So welcome. And right now, I will turn this over to Indu Navar, the founder and CEO of Everything ALS. Welcome, Indu.
Hello, everybody. It's so great to see you guys today, and we have an exciting event, and I will have Christian take over the stage today, and he'll introduce the speaker and also moderate along with Martha. So, Christian, it's all yours.
Great. Thank you so much. Hi, everybody. Yes, it's a pleasure to be here. We're really excited to have tonight's expert talk series. Reminder, of course, it is a live interactive program when you can join us here live. So your questions will be welcomed, and we'll do our best to answer every question. And it'll be available in just a couple days afterwards for YouTube if you want to share it with additional friends and family. Tonight's speaker is Dr. Eufrosina Young. Dr. Young is the director of the ALS Clinic and clinical neurologist at the Upstate Medical University. Dr. Young is a board-certified neurologist who completed her neurology residency at North Shore University Hospital, where she served as the chief resident. She is fellowship trained in clinical neurophysiology from the State University of New York at Buffalo. And Dr. Young served as neurology medical director for the Community Memorial Hospital in Hamilton, New York for 5 years before joining Upstate Medical University. Since 2014, Dr. Young has been the medical director of the ALS Clinic at Upstate Neurological Institute in Syracuse, New York. She's been the medical director for intraoperative monitoring since 2015, and it's a pleasure to have her here tonight. And Dr. Young, the floor is yours. I think we're going to learn a lot from you tonight. And as I mentioned before, any and all questions, use the chat if you need. If you want to ask a question, we will take a log of them. So after her presentation, we'll get into the Q&A. And with that, I'll pass you the mic, Dr. Young.
Thank you so much, Christian. And I'm very excited to be here this evening. I feel like you've opened the door to your homes. I think all my concerns about, what's going to happen this evening. I'm fresh from clinic. There's a lot going on, and yet you all are here. There's a lot going on in your lives, but you set this time to get together and listen to this talk. So I'd like to thank you for that. So this evening, I'm going to discuss digital health technology from a patient perspective. I think it's very important to address this because we hear about digital phenotyping, we hear about voice analysis and contributing data. We hear about remote monitoring, and yet we see it from the perspective maybe of a software developer, of a researcher, of a data scientist. But I believe something that is truly important in developing remote respiratory monitoring is to look at it from the point of view of a patient, maybe a caregiver, and a clinic setting that actually introduced remote respiratory monitoring at the height of the pandemic. Now it's 4 or 5 years after the pandemic. Nobody wants to talk about the pandemic anymore, but I need to mention the pandemic because that's when we realized that the world is a universe, as alluded to earlier by McFinn. I think that we realized soon enough that we had to go beyond our, let's say, comfort zone, right? like literally cross the bridge and find out what are other practices doing, what are other pulmonary disorders, how are they being treated other than ALS, and maybe lessons learned from pulmonary disease can be applied in ALS. So before I begin, I'd like to share with you my disclosures. We do have a research grant from Mitsubishi Tanabe Pharma America, and we do have clinic grants from the Upstate Foundation, Tim Green Fund, and the ALS Association. So everyone in the audience, I'd like you to take a moment to fill your lungs completely, right? Maximal volume, okay? So I want maximal volume, and that amount of air that you can exhale with your lungs completely full, you slowly blow it out gently and empty your lungs as possible, okay? So honesty is the best policy. I'd like you to do it now all together. So it seems easy, but maybe for the audience that are patients with ALS, it's not as easy. And if you can imagine someone with asthma, COPD, interstitial lung disease, or even cystic fibrosis, that whole entire experience would be different from an ALS patient. So how do we measure slow vital capacity? Well, we need a reference equation because we're not all built similarly. So there's anthropometric measures that we have to consider. First is age. Of course, as we get older, our vital capacity is less. Gender, women's vital capacity is less because the lung volume is less. Ethnicity, it also varies. If you're Caucasian, Black, Northeast Asian, Southeast Asian. So these things, vary. And so we don't measure vital capacity based on liters or volume. We measure it as a percentage of predicted value. So, data is one thing. You look at data on the left side and we think, okay, if it's in the lower limit of normal, then it's abnormal. Then we probably have to, let's say, rethink our treatment plan, modify our treatment plan. However, there's certain things that we look for when we measure vital capacity. Now, our respiratory therapists, they live and die by vital capacity. That's what they do. And yet, if you switch them to doing vital capacity from clinic and have them do vital capacity remotely with a patient at home and do it on their smartphones, then it's a totally different, scenario altogether. So as you know, technology can always fail. Before starting this, we already realized that my background was reversed. And this was, I think the lesson learned throughout the last 4 years of implementing digital health technology, implementing remote respiratory monitoring in an ALS multidisciplinary clinic, is that technology can fail at any time, even with practice, even with many, preparation, a lot of work going on in the background. But one thing is certain, a very specific factor other than weight, very specific factor that will affect spirometry and the value of vital capacity that is obtained is the patient's position. So I guess most of us are seated right now, we're not standing. And I remember a couple of years ago when we first started performing remote respiratory monitoring, the patient says, listen, Dr. Young, I know you want me to give it my best. I want to empty my lungs and slowly, maximal volume, exhale all that air. But I can do it better if I'm standing up. And so I wasn't prepared for that. I said, listen, we always do it seated and supine. I've never had a patient do it standing up, but then I learned to listen more closely to patients' comments, caregivers' comments, because really the entire study that has happened, over the last 3 years, a lot of it has been improving a methodology based on patients' comments, patient experience, that feedback that we're getting from caregivers. So a CT scan was done, patient in supine position, standing position, and seated position. And as you can see, they demonstrated that in the supine position, the lung volumes are really much smaller than they are in the seated position. And compared to the standing position, inspiration and expiration in the standing position, you have the greatest lung volumes. So this specific approach of testing vital capacity in the seated and supine position is really key, because more often than not, majority of clinics, ALS clinics, can perform pulmonary function testing at clinic. They have a respiratory therapist, but these tests are done in the seated position for the very reason that there are some patients who just cannot transfer to the gurney. You know, some of our patients are wheelchair bound. We still test their vital capacity, but we cannot test in the supine position at clinic. So here we are talking about remote respiratory monitoring. We're testing patients from home, and that allows for us to actually test more often successfully in the supine position than we would be able to in the clinic. So when we were debating over how should we approach our patient population, very specifically ALS, ALS is not pulmonary fibrosis, it's not interstitial lung disease, it's not cystic fibrosis, it's not COPD. So I'm showing you a graph on the left side of the screen, wherein pulmonologists, see a whole gamut of different patients with pulmonary disorders, and how do they respond to home-based spirometry. So majority of these studies have been done in pulmonary disorders, not ALS. What happened when you increase the frequency of testing going from weekly to daily is your graph from left to right. So adherence, which is the ability of participants to perform these testing as you prescribe them to perform them, decreases over time, anywhere from, let's say, 95% to 55%, just by increasing that frequency from weekly to daily. So why is this important? Why are we talking about vital capacity? So we know that based on the vital capacity, we can prognosticate. And it's not just prognosticating disease progression, it's prognosticating survival. So majority of our patients die within 2 to 4 years of symptom onset, right? And the cause of death is respiratory failure. There's the death of motor neurons that are supplying innervation to the diaphragm and the chest wall muscles. So we must speak about vital capacity because that's our metric. That's how we determine patient outcomes. And I'm sharing with you the data from 2018. Dr. Andrews and Dr. Jeremy Scheffner wrote this article, and it tells us that vital capacity declines per month at a slope of 2.7%, more or less. So that is the slope of decline, 2.7%. And this data is based on hundreds of patients, right? So there's 3 trials, Empower, Benefit, and the PROACT database, wherein they looked at more than 800 placebo participants in those trials that they looked at, and found that on average, the patients declined by 2.5 to 2.7% per month in terms of their vital capacity. And this is not a stratified database. This is all patients, all patients that are participating in a clinical trial. And you might say, well, these conclusions are very specific to the participants, the people that participate in the clinical trial, in the same manner that our conclusions are very specific to our small university hospital setting. And our trial was done engaging 2 university hospitals, one in North Carolina, Atrium Health, and ourselves in Syracuse, New York. But I'd like you to remember this slope, okay? Because this slope will have implications in our small trial. So here you can see what our participants are engaged to do. On the right side of the screen, even with paralysis, the mirror spirometer, which is what we used, can be attached to a table, and the patient able to can seal his lips around that mouthpiece. And you see that smartphone, the personal smartphone is right there, and the patient can see the flow volume loop that he generates as he breathes out of the spirometer, as he does the exhalation and inhalation. So on the left side of the screen, you see that flow volume loop. Now, before he does all this, of course, we need to get consent. And before that happens, he needs to download the app on the smartphone. So more often than not, our patients come in to our clinic, want to participate in the trial, and have their caregivers next to them, to allow for them to download the app. Everybody downloads apps these days. It seems very elementary, but a lot of our patients need help downloading apps. And a lot of our patients, need to be able to understand, in a manner that they can actually consent to sharing their data, because this is still private patient health information that's going on a database. So we find that the consenting is very important. Patients have to understand that their information is on a database. However, when it comes to analysis and statistical analysis, these are not their names that are showing up, but they're converted to numbers. But nevertheless, this is still patient data that we must protect. And in the left bottom half of the screen, you can see how we are basing our quality, acceptability, and reproducibility, and making use of the Global Lung Index as a reference equation, and making use of a grading scale wherein we can determine if the quality is at par with a grade of A or a grade of E. And this is important because the American Thoracic Society and the European Respiratory Society 2019 guidelines gives us the criteria for what you would conclude as an acceptable vital capacity recording, what we would conclude as a usable vital capacity recording. And these grades in the lower half of the screen would tell us that if you're comparing one study with another, more or less you have to know that they're equal in terms of the number of vital capacity measurements of similar grade. But let's say from grades A to E, majority of the vital capacity measurements fall between A and B. So those studies are comparable. So we need this to anchor, our data. Okay. So on the right side of the screen, just shows you that, with loss of dexterity in hands or loss of sealing ability because of weakness in the lips, there is that aspect of monitoring vital capacity that can diminish over time, for which, the caregiver truly has, increasing importance, in ensuring that our patients are able to monitor over the course of time. So we're ready to deploy. Cystic Fibrosis Foundation, at the height of the pandemic, just a quick phone call. Hey, from Syracuse, New York, we'd like to know what you guys are up to. And the response I got was, well, we've shipped 13,000 of these portable spirometers, and we're going to use a data dashboard and so forth. So I said, well, then how do we do that? Right? How does one get initiated and taught how to start remote monitoring when there's chaos all over and we don't really know, like, how are we going to learn this method? And true enough, it was really a phone call. I hate to make it more dramatic than that. It was really a phone call, and finding out that the software developer, we live in Syracuse, New York, was in Albany, New York. So they're not too far, and they were very easy to talk to. And we said, we want to do this. We want to implement this remote respiratory monitoring in our clinic. We did know, based on prior studies and pulmonary studies, that we must use our gold standard, which is the VIASYS system, and that is the conventional spirometer that we use every 3 months when we see our patients in clinic. However, the world is different. The universe is different. Now we have to switch to telemedicine, and we have to figure out a way of monitoring our patients from home to ensure that their disease, is either held at bay, or if it was declining, we would be aware of it and we would know how to modify the treatment plan. So we engaged our patients to test at clinic. So we did their clinic conventional spirometry, seated and supine, on the right side of the screen, our gold standard. And the same day, or within 7 days of that testing, we engaged our patients to use the portable spirometer and also, again, test in the seated and supine position so that we could compare. We want to make sure that our data is anchored onto the gold standard. And then we were ready to ship the patients home with the portable spirometers. Our intent is to be able to follow our patients from home every 2 weeks. It was also our hope that our patients would still return to clinic every 3 months. So within a period of 6 months, we would have a baseline test, a test at 3 months, and a test at 6 months. But in between, we would allow them to engage with our respiratory therapist and test from home. And clinicians, the team, would be able to access that data and then make treatment changes based on the information obtained. But of course, it's never easy. I mean, the illustration is one that tells many stories, and also the illustration simplifies a process that appears simple, but there's a lot of this work that goes on in the background, and it's amazing that the whole program got put together. Because at any point in time, something can go wrong, and it will go wrong. So first lesson we learned, and right off the bat, when we started the journey, from 4 years ago, we knew that digital health technology is a tool, but that's not the end of the story. The data collection will allow for us to extend our care for our patients. The data collection was not the end goal of our endeavor. We just really wanted to know, how do we take care of our patients better? So there is a software application that is downloaded on the cell phone, and we're able to access a clinical dashboard, a clinician dashboard, as you can see, and this data dashboard is accessible to clinicians. But on the left side of the screen, as you can see, patients can also see the results on their smartphone. And so you would think that, well, most patients would like to know. Well, actually, no, some patients don't want to know, particularly if their vital capacity is not stable. If they're seeing a decline, it can trigger, all sorts of thoughts, sometimes trigger anxiety, sometimes maybe it leads to this change of heart. That in the beginning I wanted to participate in the trial because I thought I would be contributing to the good of the management in ALS. But then now I'm rethinking it, and I'm developing this anxiety that it actually caused some of our participants to withdraw. But there were only a handful of people that withdrew, and I have to say that I believe it is from the continued interaction of a respiratory therapist, a human being, not an animated representation of a human being or an avatar, but an actual human being that interacted with a patient on the cell phone, on telehealth, that allowed for our patients to make that self-determination that, hey, they're not just collecting my data, they're actually using the data they collect in order to let me know where I'm at with my disease and what changes I need to make in order to remain stable, in order to improve or decrease the risk of developing an infection in my mouth, in my throat, in my lungs. So there is that. We were not giving people drugs. This is not a drug trial. Majority of trials that are more observational, very difficult to engage patients to adhere, throughout the duration of the trial. But I have to say that the role of the respiratory therapist here, the supervision, of a human in conducting this trial, made a whole world of a difference. So then we do have patients that disengage, as I said, because it increased anxiety. And one thing that I have to say, to add to this, is that what increases the anxiety of the clinician is when all these information are disconnected. So there is that effort to connect the data from the data dashboard with electronic medical record. And going to the right side of the screen, that helps the whole team engage, as opposed to, logging on to a different username, password, and getting on to another screen in order to get this information and put it together. Any effort to integrate with electronic medical record, or EMR, is really very helpful, because data is only data when you access it, and access it quickly. And what we learned over this time frame is that some of this data is really actionable, and some of this data is allowing for us to improve the care. So lessons learned: it's a collaboration between neurologists, pulmonologists, respiratory therapists, nurses, clinic coordinator. It's a team effort, and it's listening in on what patients and caregivers have to say, because they're the ones performing these repeat measurements. On their end, it may be 10 minutes. On the end of the clinic, it may be hours. But then there are situations wherein, we think, oh, the internet failed, and therefore the patient tried to use this barometer and then was unsuccessful. But then there are other glitches, and these glitches you realize as you go along, because you're actually, in a sense, vetting the whole entire system in your clinic into the hands of ALS patients and caregivers, and making a determination that, yes, this is very helpful, for you, for the clinic, and maybe in the future for research. So the clinical staff and the caregivers are aware that at-home telespirometry, or AHT we called it, influences changes in the treatment plan, and we improve as we go along, and allow for the best outcomes. So this is our study. So it went from 2021 to 2024, and currently we're doing analysis. And this is just showing, part of the analysis has been shown in a poster at the American Academy of Neurology. So we want to make sure that the data we're collecting are, number one, they're of high quality, and number two, that the data we're collecting is anchored onto the data that we obtain with conventional spirometry. So what's portable spirometry and what's conventional spirometry? Are they giving us the same results? And what we're seeing here in this analysis is that the results are really very similar. However, the limits of agreement may be wide enough for us to say that you cannot just feel comfortable about shipping these spirometers to patients' homes and never seeing these patients, at clinic, and feeling comfortable that the data that you're obtaining are truly high quality, reliable, repeatable, and acceptable. So we still see our patients at clinic, because we need to make that connection. And what we did over a 6-month period of time is to test every 2 weeks. And at the onset, when the patients enroll and we obtain their baseline vital capacity using our gold standard conventional spirometer, we figure out a way of analyzing where they're at in terms of progression, and where we could be at in terms of using these measures, outcome measures, to prognosticate outcome. Now, in the bottom half of the screen, you can see we're doing it in the seated and supine position, slow vital capacity, and we're breaking down, the vital capacity less than 60% red, which is our lowest tertile, so maybe lowest performers, 60 to 80% in green, the middle tertile, and greater than 80% in teal, the upper tertile, the high performers. And it's important to be able to order the data this way in order to stratify, have a strategy wherein we're stratifying our patient population so that we can determine where people are at and how they progress over time. Do some patients stay stable? Do they plateau? Do they decline over time? Is it an up and down? We all assume it's a downward spiral, but some patients are up and then they go down. Some patients are down and they go up. And it gives us, insight. And this is what I learned personally from, our respiratory therapist, a respiratory coordinator, that the manner by which these vital capacity measurements are obtained is very important. We need to be able to ensure the quality by making sure that our therapists are trained even if they're experts, but they're trained to obtain this test remotely. And we need to ensure that we have a proper seal, that the technology is working. If there's any updates in the firmware, in the hardware, in the software, these all three are talking. And so there's a lot of this, that we learn over time. And I think that if you recall earlier, Dr. Jinsey Andrews' graph, wherein the conclusion was about 2.5% drop slope per month over time was average among 800 or so patients that were participants in the trials, including PROACT, and in the placebo group. Where we're seeing is that if you break down our participants, 98 participants, into tertiles based on their baseline conventional spirometry, again, the three tertiles, less than 60%, 60 to 80%, and greater than 80% slow vital capacity, that 2.5% is actually looking more and more like our group in the less than 60%. So we'd like to be able to use this approach in order to make a determination that patients may belong to one tertile. However, there may be ways of improving outcomes, right? This, based on Dr. Andrews' research, is that if you look at that 2.5% rate of monthly decline in all the databases, and if you slow the decline of vital capacity by 1.5% per month, you're actually reducing the risk of respiratory failure by 20%. So lessons learned. First, we learned from the pulmonary doctors, pulmonary disorders. This is the approach they had using digital health technology and remote monitoring. And it's acknowledging that ALS patients are not COPD. ALS patients are not cystic fibrosis. There are similarities, but there's also major differences that we must consider in order to allow for our clinical trials, our clinics to be designed around ALS patients. So this illustration, had many alterations. I think that everyone had an input on how it should look like, where the arrows should be, which one should go first. But I think we start with the technology. The technology is available. It's been available for, I believe, more than a decade. I look back at an article dated 2018, and there were already 18 of these portable spirometers. Of course, some of them were FDA approved, others were not. But as you can see, it's an exploding area. And so we start with the logistics. What do we have to deal with? How are we accessing the data? Who is going to access the data? And then we go on to our patient population. We need human supervision, and our respiratory therapists, our respiratory coordinators, they are key. They also have a learning curve in terms of implementing remote monitoring, but their wealth of information, and I personally learned a lot from them. And then we have the clinic. This is not just the neurologist or just the pulmonologist or just the respiratory therapist. This is a whole project in and of itself, wherein all the members of the clinic are aware that we have a focus. We're focused on respiratory care, and we engage our patients, to improve their care by making sure that they're performing airway clearance techniques. We revise treatment with cough management, secretion management, and we aggressively early on introduced non-invasive ventilation, because again, looking at that curve, we know that it's a race against time. Our patients do not have the time to wait for medical insurance and Medicare to approve their non-invasive ventilators. So I think when I prepared for this talk, I looked at all the information out there, and these three articles are must reads for anyone interested in pulmonary function testing, looking at non-invasive ventilation and the effect on survival outcomes. So lastly, this is our little village. I'd like to thank everyone Special thanks to Dr. Anuradha Dilip, our medical director, Dr. Benjamin Ricks Brooks, who really mentored, the whole trial and venture into digital health technology implementation in an ALS multidisciplinary clinic. And I'd like to, thank all our patients, their families, the caregivers, and I'd like to thank our ALS coordinator, Stephanie Lesson, who really, provided all the positive influence, on the entire clinic to embark on this journey. Thank you.
Thank you so much, Dr. Young. Thanks for that great presentation. Lots of lessons learned that go back several years now, and really glad to see that the clinic is putting this into practice. We're going to get into some questions and discussion, I think, from here. So I'll jump in and take the first question from the audience. Clearly, there are different numbers for seated, standing, and supine tests. Is there value in doing more than one of them, or do they show similar changes over time?
Yes, so most clinics perform vital capacity testing in the seated position. So that's probably universal, but there's value in obtaining it in the supine position, because that's when essentially you're taxing the diaphragm. So as we showed earlier, the lung volumes are much less in the supine position. So I had that one patient say, well, I could do better if I stand up. So would you like me to do it standing, seated, and then supine? It's probably a little bit more, data than what we need, because we already know for certain, and based on, several research articles and publications, is that, when you test, with this change in position, you actually are able to make a determination with higher sensitivity, of diaphragmatic weakness, maybe even paralysis at a much earlier stage.
Thank you. I'll jump in with a discussion point as well as we get a couple more questions here. You've obviously learned a lot, and your team has learned a lot about what's different with people with ALS when caring for them remotely, and have really embarked on and proven the importance of remote functional assessment. How close do you think we are, or what would it take to ensure that remote functional testing like this, doing it remotely, would be a standard of care across the country? Or that it be, do you feel like the publications there or the research there, are people being denied that too often by simply a lack of adoption of these practices across America and across the world?
Yes, I think what we've learned here is that there's a real value, in implementing remote respiratory monitoring for our patient population. And I've had, discussions with multiple, from multiple different viewpoints. And I think that there is a need to ensure that, number one, the data is out there, okay, and that people can replicate, what has been done in two institutions, to ensure that, it's applicable, in other places. And they can see that once remote monitoring was implemented in our institution, what we realized is there is no turning back, because we now have that ability to be able to intervene, way before a 3-month follow-up visit at clinic. We have that data in our hands, and we know that patients are declining. We don't wait, for them to come to clinic before we say, hey, you need to clear your airway. We need to get you started on mechanical insufflation, exsufflation. So a lot of these have other far-reaching implications. Say, for example, we have a patient whose vital capacity is declining and is still contemplating, is still on the fence about getting a feeding tube placed. Well, maybe, knowing that this is the trend, that decision-making is in a way accelerated for the good of the patient in order to prevent, complications from trying to put in a feeding tube late in the course of the disease. So you asked a very good question, and I'm afraid I don't have the answer, because the people that I've talked to tell me that, number one, these publications, they should be out in the open. The discussions should be, in many forums, not just a few of them. And, Medicare, we need to have an audience, and they need to know, how it's transformed, a small clinic in Syracuse, New York, and how it's made, our ability to care for our patients, so much more optimal. So there's multiple steps. I believe, we're part of a village, maybe the smallest part of a village. It takes a whole village to, be able to share and implement this as part of, standard of care.
Being so focused, that's great. Thank you for that. And being so focused on the pulmonological aspects, how do you feel this is being integrated, your practice, your view of it from when it comes to respiratory function, salivation and secretion? These are all things that people here, are worried about and have to contend with from just an everyday experience. How much is that being integrated, in your opinion, to a more holistic sense of care? When it comes to the various functions, each function represents potentially different areas of neurology and different areas of expertise with OT and PT and other people. We have this ALS FRS functional assessment overall. How is this feeding or a potential, innovation or improvement in how we're measuring progression? Yes.
When I think of integrating it and how the experience has been, in the last 4 years, it's very methodological. It's very step by step. There's just one rigid path, and there's no, veering away from that path. I say that because when you talk about, introducing a whole new world, essentially, to a universe of different, aspects of function, it's like climbing a mountain. I feel that there's a lot going on in an ALS clinic, with the various disciplines that support the ALS clinic, that for one to turn around and say, hey, there's an aspect of care wherein we know that our patients are dying from respiratory failure, that we must now look at very closely and, look ourselves in the mirror and say that, are we doing enough? Or are we doing so little because we are so much burdened, by everything else going on? And I feel that this is where you walk in and say, the technology is there, the innovation is there. We just need to understand it. We need to understand it in the context of implementing it for our patients. It's not translating what COPD does for their COPD patients or cystic fibrosis did for their cystic fibrosis network, but actually implementing it in such a way that it is compatible with the needs of our patients.
Thank you. Got a few more questions from the audience here. So how do you adapt testing for bulbar onset patients that can't close their mouth fully? Are there any tips for better readings if you can't close your mouth or lips to get a good seal on the spirometer?
Yes, and that problem, thank you for that question, is not uncommon. When our patients are not able to seal their lips around the mouthpiece, our respiratory therapist would fit them with a mask, a face mask that allows for them to maximally blow out into the spirometer. So there has to be, no leak or minimal leak around the face mask or around the mouthpiece, because any leak would really render the test of poor quality. It's going to, register, and we are going to get much lower results because air is leaked out. And this is one thing that, the respiratory therapists are very keen about, because patients are asked to repeat a couple of these, in several efforts in a series, and they can tell if the variability is such that it is not supporting, tests that is of quality. And they can also make a determination that, the patient's really struggling, and maybe we shouldn't be using this data, and maybe we shouldn't be doing remote monitoring because we know that the data is not reliable. And so this is, again, the human interaction that engages the patient to give their best effort, and at the same time utilizing the technology that's built into the firmware and the software in order to detect, certain grades that will allow for adequate interpretation.
Thank you so much for that. Yeah, I think we've got a couple of questions here on the more from the perspective of the care provider side. So I'm going to invite some perspectives from the audience too about what you experience and what you've struggled with or what you worry about too. So if you have any observations, any thoughts as well, we don't have to just have it be Q&A and just questions for Dr. Young too. So by all means, share your experiences, and if you're participating in any remote care, we'd love to hear from you too about what's working and what isn't. And I think I'm going to tie it a little bit to another question from a provider who asked, my PALS has not been doing his breathing exercises, blowing and sucking air. Can you help me by saying something that I could use to motivate him to do his exercises? I think it's just important for the audience here of our fellow PALS to share your perspective on what motivates you to keep doing your exercises. So Dr. Young, while you talk, I'll invite others to share their thoughts too.
Yes, I think breathing exercises as well as airway management, hygiene, oral hygiene, I think they all come together. We encourage our patients to use a cough assist, oral suction, making sure they brush their teeth as well as their tongue, and the goal really there is to prevent you from developing an infection. You can develop an infection in your tongue, in your mouth. If you develop thrush and I look into your mouth, I don't know how deep that goes down your throat. If you develop an infection, it goes into your lungs. You develop a pneumonia that requires hospitalization. So I'm not trying to scare you. I'm telling you, this is exactly what's happened to many patients. And in order to be proactive, we want to be on the preventive side. I don't want to see you in the hospital. I want to see you at clinic. And so I think these are discussions that we frequently have with our patients. And I think it is motivating them in the sense that my routine before and my routine after I was diagnosed with ALS is now different, and yet we're all on the same page that looking at survival, looking at what we've learned in the last decade about what prolonged survival, use of non-invasive ventilation, use of mechanical insufflation, exsufflation. All these, are utilized by the patient with the help of a caregiver, and therefore, we must, emphasize that the effect on survival for, the usage of early non-invasive ventilation and mechanical insufflation, exsufflation far exceeds, the effects that we have currently with the drugs that are available. So drugs slow down disease progression. We need them. But at the same time, we must acknowledge and we must relate, with our patients in their struggles if they're having difficulties using devices that we, encourage them to use. Cough assists or mechanical insufflation, exsufflation, breathing exercises, and usage of non-invasive ventilation, which would not be possible unless, you perform all the necessary steps for airway clearance.
Thank you very much. Another question from the technology side. Can smartwatches be used to monitor SVC? Is there any technology that you know of yet that's been released to do that?
Not that I'm aware of. Now, there's a difference between passive and active technology, right? So I believe smartwatches, tell you your heart rate, stuff like that. But when we talk about active technology, you actually have to engage someone to be able to obtain the data, right? So it's not just passively worn. It's not like determining number of steps, 1,000 steps this morning. And just continuously recording. So it's not passive that way.
And one more question. How has the use of remote pulmonary function testing impacted the care and treatment of patients in the clinic? Earlier use of ventilation or cough support, are patients followed by remote testing surviving longer? You started to get into that a little bit when it comes to just managing care better. Do you see that this is also something that is able to cross into other aspects of integrated care, whether it's OT and PT and the different functional aspects of really collaborating with people with ALS as they take care of their own care from home?
Yes, so the impact is tremendous. And when I talk to, patients, families, my colleagues, when I attend conferences. This is a point of no return, essentially, because of what we've experienced, what we've seen. The response from our patients is incredible. Of course, there are those patients where it didn't click. It made me so anxious I had to just withdraw from the trial. But majority of patients tell us that because you monitored me, I was able to, get engaged with, airway clearance techniques. I was able to ensure that, I do everything I can to prevent myself from getting an infection. And because you monitored me, I was able to get started early with non-invasive ventilation. Now, it comes with also, sharing that information, because most patients will not know that starting early non-invasive ventilation is actually, equated to longer survival, unless we have that discussion. So the education piece here is not just educating the patient, it's educating the entire team, from the respiratory therapists to the clinicians, and also educating the researchers and the ones that are running clinical drug trials. So we are all kind of dovetailing on each other's knowledge, the neurologist learning from the pulmonologist and vice versa. And I wanted to share this with you, and how it impacts other things that we're doing. I alluded to earlier about patients that are maybe ambivalent about getting a feeding tube placed. And, it came as a criticism. And I love to share the criticisms because you learn so much from it. It really depends on your point of view. The criticism from our interventional radiologists and surgeons that put our feeding tubes in is that you ALS clinic, you send patients to us way too late. They're so complex. By the time they reach the interventional radiologist, there's complications that come up because you should have had a discussion with patients about putting feeding tubes far earlier than when you send them to us. So we dissected that, and figured out what's happening in the clinic, what's happening on our end. Is it lack of, discussion? Is it a lack of education? Is the clinician slow? Is the nurse slow? So what exactly is happening? But what we've experienced, in the last 8 months, working side by side, with our interventional radiologists and coming up with a program, wherein our patients are actually seamlessly integrated into, interventional radiology to get their feeding tubes, is that the vital capacity trend, and that information that we're able to relay to a patient and as to where they're at, as we've trended, not a one-time vital capacity test at clinic, but trended over time. And the patient can now have that information in order to make the decision whether they will proceed or not. If majority of patients proceed with having a feeding tube placed, then also a lot of patients are ambivalent about it. But then this information helps, that decision making. So now we partner with our interventional radiologists. We've changed our whole clinic system in a way that we're focused on respiratory care, and this is actually moving along our ability, to allow for patients to have their feeding tubes placed in a safe and timely manner. So that's one aspect, of how, one thing led to another. We didn't know that it was going there, but it actually helped move that along. So that in itself, we'd like to be able to measure that effect, and have, a deeper understanding of how did this all come about? Are we now seeing less patients come to the emergency room? Are we now seeing less patients admitted to the hospital? These are conversations, these are observations, but then they actually, need to be looked into a lot deeper. I was told that our hospitalists and our palliative care team in the hospital do not see ALS patients. And why is that? Because the clinic is doing a lot of the legwork to prevent people from getting into the ED and getting admitted to the hospital. And one other thing, again, an unintended effect. 8 months ago, the hospice in our area made this announcement that they were not going to be able to care for ALS patients any longer. And why is that? You know, because your patients are living longer. And so if you take a step back and kind of like shake off uh, I don't know, for lack of better, annoyance or disappointment that our patients on non-invasive ventilation are not getting access to hospice care, and if you think about what is underlying that, well, what's underlying that is if patients are truly living longer, then these services don't have enough funding support to be able to care for patients that survive more than 6 months than you told them they would. So in a sense, it's a good problem to have, but we're all interconnected, and these services have to be able to come together and say, our goal is to allow our patients to live longer, right? It's living with ALS, people living with ALS, and therefore our services must be modified, our services need to change, our services need to be enhanced, our education must increase, over time. Our patients' care must increase over time, not decrease.
Yeah, absolutely. And here at Everything ALS, we're here in the business of making sure that everything gets done sooner, better, more predictably, so that we do keep elongating the time that everybody has, because we're here for the cures. So we want to make sure that that's on the table all the time. We do have a question. Is there a prevailing opinion about the type of cough assist that is preferable, like vest versus mask?
Actually, I just had this conversation with our respiratory coordinator a few hours ago. So my understanding, and there's my colleagues in the audience, our patients with cystic fibrosis, for example, they're strong enough to be able to put on a vest, okay, and have that vest oscillate and allow for secretions to be removed. I personally have not used these oscillating vests for our patients because I find our patients tend to be on the frail side. And using mechanical insufflation exsufflation has been demonstrated to be effective, in allowing for airway clearance. So I tend to gravitate towards mechanical insufflation exsufflation and not use of vests.
Thank you. And I think there was one more question. If you could repeat kind of just a summary of the benefits of having a feeding tube. We have someone whose husband was told to get a feeding tube within 6 months of diagnosis, but he hasn't paid much attention to this. Of course, I'm sure everybody's different, but if you could speak to the importance.
Yes. So essentially, no feeding is not compatible with life, right? If someone was not able to feed at all, that would be an emergency situation. You'd end up sitting in the emergency room and having an emergency feeding tube placed, and that would not be a good situation for many reasons why emergency surgeries are not, a good outcome. When we talk about feeding tube placement and we talk about how respiratory care enhances, feeding tube placement, it's in the context of feeding tubes being placed way too late to the point of developing complications from the feeding tube procedure. So from the point of view of surgeons and interventional radiologists that put in the feeding tube, they have to be able to situate a patient, position the patient supine or, more inclined in order to find that window to put the feeding tube in. And then they, insufflate the stomach and then able to insert the feeding tube. Now that procedure may essentially be, textbook 10, 15 minutes and you're in and out of there. But that's not for an ALS patient. If an ALS patient is already compromised in terms of respiratory function, then you can imagine, as we talked about earlier, having them lay supine may be impossible because they'll stop breathing. Right? And a patient who's, very frail may no longer be able to tolerate the sedation that's necessary to keep them comfortable. Majority of patients do not want local anesthetic when the feeding tubes are being placed. They need to have some sort of sedative to be able to tolerate the procedure, even if it's just for a few minutes. So because of that, tendency for feeding tube placement, the actual procedure in itself to become complicated to the point that is it possible to aspirate, during feeding tube placement? Absolutely. And if you develop a pneumonia within, 24, 48 hours of feeding tube placement, you very well know that that's a complication of feeding tube placement. So there's all this, worry that comes along with feeding tube placement. So patients are ambivalent, about committing to feeding tube placement, especially when, they're still having a full meal or they're still tolerating a diet that is modified in consistency. We understand that hesitation, but if we're able to trend, the vital capacity, not every 3 months, because we know a lot of things can happen, in that 3-month period of time. But if we are able to trend the vital capacity and know where we're at in terms of the patient's trajectory, then our conversations with our patients tend to become more meaningful, because we have data. We're showing you the data and you can understand what it means to trend downwards. And this is where we're at. And maybe, you should consider having a feeding tube placed sooner than later.
Thank you so much for the explanation. We've got one more question I'm going to take from the audience on this, specifically to around the topic of spirometry. So is there a way to link the spirometry data to optimize the settings for NIV and cough assist?
Yes, so I think that when we do spirometry and we know that there is a downward trend or patients already increasingly symptomatic with breathlessness, we want to be able to set the tidal volume. And tidal volumes are set in order to allow for the patient to have a good full inspiration, right? And so, setting the non-invasive ventilation, that tidal volume, that the patient breathes in and out would be necessary because you would set the tidal volumes much higher, right? If the readings that you're getting from the spirometry is much lower. So the way I think of vital capacity, but the spirometry reading of slow vital capacity, is that it's a good gauge, of where a patient is at. And when you've already introduced non-invasive ventilation, you don't stop, measuring that vital capacity, because again, introducing non-invasive ventilation, we believe should not be tied to a number. It should not be tied to 50%, absolutely. It should be, interpreted on the basis of what is the trend? Is the patient symptomatic, right? Is the patient already desaturating at night while they're asleep? So there's other, factors that are involved. But, in order to make a determination of what settings should be for the non-invasive ventilation, yes, the spirometry readings are a good gauge.
Thank you. Excellent. I think we'll close with that. Thank you again, Dr. Young. Here at Everything ALS, we are working on our multimodal studies. Our Radcliffe study, also our speech study is ongoing, where we do collect things that are related to that really interrelate between the types of data that are being collected, all from home, and wherever it's needed, we can proctor remotely as well. The same lessons you've learned, we're applying with our observational studies, and we are certainly interested in helping helping continue the adoption of remote care and remote engagement with people with ALS to make every single measure possible available at the right time, so that interventions can happen earlier and the right decisions can be made earlier. So thank you again for all the work you're doing, and we will definitely be following up with you and keeping up with you on the work you're doing and making sure every other clinician out there knows about it.
Great. Thank you so much.
Thank you, everybody. Doctor, I hope that you take some time for yourself in your life. I know how dedicated you can be to all of us. So please keep that smile on your face and do something for yourself that really makes you feel good, so we can depend on you lots longer.
Great. Thank you so much for having me. I really appreciate this opportunity. And I think, with the words that you shared earlier about the universe, that really set my mind at ease. And I felt like, I'm talking to friends.
This is an extended family. Everyone here has something very much in common. And then we have a lot of specialties because, everybody's different. Everybody is special. Everybody has something to offer. And it doesn't have to be anything about ALS, or it can be about anything. So I just want to say this is the time of day, folks, when I get to see Glenn, who I haven't talked to in quite a while. Glenn, it's so good to see your face here. This is our time. Yes, you, my friend. Thank you. Aha. Once again, this is the time when we can talk about anything. But if you'd like to talk about having a breathing problem, how is everybody's breath doing? Everybody, okay. Well, I'm glad about that. Thank you, Gary. Thank you, Eddie. It's folks, this is it's a journey, and each of us is on the train together, and that's why we need to chat. We need to bring up the things that didn't work for us last week. Then we bring up the things that worked for us last week. And those are the kind of conversations when we have 60, 71 people, we have a lot of information. We have a lot of experience. And sometimes we're more experienced than the doctor who's treating us, because they're doing the jobs that they were taught. And we're doing the job, I should say, on the job training every day about how to make our days a little bit better and easier to get through. And one of the things that I find is that when you look in the mirror and you see those eyes looking back at you, there's a being in there who really cares about you. And so I kind of tap every once in a while and say, hello in there, how we doing today? It's been a great day. Don't ever hesitate to know that there's two of you. There's somebody along the trip with you. And when I was paralyzed and could only move two fingers in my head, I had a great friend, and it was right inside of me, and I could talk to it any time, and it made me feel like somebody knows what I'm going through. Because it's kind of hard sometimes for other folks, especially your friends, to know how your day went and how they could help a little bit more. And once again, McFinn's tongue just loves to keep on going. So don't let me get in the way of somebody,
Yes, it's good to see you. And this was a great session. And I'm having breathing issues, and I'm using a cough. I just got a cough assist, and it is helping exercise my diaphragm. And I would mention to our community, if you are having issues, reach out to your pulmonologist as quick as you can. And the doctor.
Yeah, Tony. Folks, when things are going sideways, it's always good to contact the doctor and not say, oh, I've already been there. Oh, I've already talked to him. They work for you. They are there for you. And most of them want to hear what's really wrong. And they want to hear how you can be part of the solution. Because, we are more than we seem. Hello? Hi there, Joey. Hi there. Thank you. Oh, and you got your angel. Oh my gosh. Life is pretty sweet when you have somebody who you wake up with and they say, what can I do for you this morning? What can I do for you this afternoon? And then sometimes you say, what can I do for you? Because you know what? We're not helpless. When you have ALS, that's only part of your life. And some people, they kind of say, I have ALS and that's who I am. No, you have ALS and then there is who you are. And so that's the person that you want to never lose track of. And the mirror is a wonderful place to visit and just look, sometimes talk out loud to yourself in the mirror and see how it feels. You're talking to that being inside, and that being loves a little company, because most of us are busy trying to figure out how to get out of this ALS. And so, but it's good to take a break 3 or 4 or 5 times a day and tell yourself how much you love yourself. I mean, food comes emotionally, physically, mentally, spiritually. There's all kinds of food. And this world has a, what do you call that? A buffet waiting for you to take your choice. I mean, there are so many options that we can take, but we have to hear about those options. And that's the job of our extended family. So, who's got an extended family gift? Who had? There you go, Gary. Welcome, friend.
Before you go too far, for all the folks that are, I know in the ALS progression that each person is different, and each person react different. But if you're in a position where you're contemplating, should I have been due to stall? I've had mine for a year and a half, and I've never used it except for every day, every other day, flushing. That's it. So don't be afraid. That and I'll put it doesn't mean you're at any point in progression of this disease.
Thank you, Gary. Those are folks, like I said, each one of us has something to offer because we have different experiences every day. I just want to reach out to you, Elizabeth, and say, I don't get to see you too often, and it's so nice. Your laugh, you're my old friend. We've been doing this for quite a while together.
Yes, we have. How are you? And hello to all my pals.
That's right, folks. Elizabeth has been with us a long time.
Yes.
And it's I love to say that, a long time, and let's keep it being longer and longer. It's
I also wanted to say that I was participating in a small trial that Columbia Presbyterian had. And it was a trial involving two natural roots, licorice root and hibiscus root. And it helps, from what I can say, from what I could observe, it helps very much with the spasms, those terrible spasms that you get, in my case, in my gut and in my hands. It has helped me. So it's called, I believe, TC68. The only catch to this is that you can only get it from Japan. It's readily available there, but you have to do it through Japan's Amazon. So as soon as I get more information on how much it costs, I will let all my pals know.
Elizabeth, can you please repeat the name of the roots? You said hibiscus and the other one was what?
Licorice.
Licorice. Thank you.
Licorice.
Yes.
Hibiscus, licorice.
Yeah.
beautiful.
I understand that Chinese medicine also uses it. I haven't done my research on that, so maybe it's something that we can research. But I found it helped me.
Good. Awesome.
Thank you for sharing. I have a question. Does anyone have experience with having inflamed armpits during the course of your disease? Has anyone experienced anything like that?
You mean like the lymph nodes? Is that what you mean?
Inflamed lymph nodes and very painful underarms.
I've experienced painful underarms.
Do you associate that to any medication in particular?
No, I just take aspirin for it.
Thank you.
Elizabeth, that was a lot. Thank you so much.
Yeah.
You know, folks, yes, go ahead. Christian.
Real quick, Eric, great to see you. Eric Brown's got a question. He was agreeing with Gary about the feeding tube and that it's better early than too late. And Eric was sharing that he'll be starting on the ventilator 24/7 as soon as the second vent arrives. But he did have a question for the group if there are any suggestions on mounting the vents on your wheelchair, because it's a frustrating part, but it's frustrating, but it's part of the journey. Prayers needed to stay ahead of the wave. Eric, we're always praying for you, man. But if there's any suggestions there about mounting the vent on your wheelchair, he would much appreciate it. Well, then we will put it to our pathfinders to find out.
Okay, I know who to ask. I wish that, where is he? No, our friend isn't here tonight. I have to say something. We have one of my good friends. His name is Sean. He's a pathfinder. And Sean's got a little bandage on him. And I'm not going to ask him to talk, but he wasn't being able to be with us the other night. And I was wondering what happened to him. And now I see that, can you talk, Sean?
Oh yeah, this unfortunately is a new little addition that just happened today. I was in Vancouver for a neurologist appointment and filling out for gas, and I went to go do my windshield, and I tripped over the gas hose and split my chin, falling over, and of course my arms couldn't stop me. So, yeah, the joys of not being careful.
My goodness.
Almost.
Thank you, Sean. That is a really good observation about slowing down, being conscious of every step.
Surroundings, yeah, absolutely.
Because we have time to do that.
Yes, we do. We should.
Well, thank you for sharing that with us, Sean. Sean is one of
on the good side. I had a very good neurologist appointment, and my neurologist was happy that my progression is as slow as it is. It's been a year since I was diagnosed, and I'm kind of sort of the same, but things are going well. So he was impressed with my my lack of progress, I guess, is a better way to put it. Yeah.
And what part of your body is affected? Is it your hands?
Yeah, it started my hands. So right now it's my biceps. I'm having a hard time lifting. My hands work okay, but it's my arms that are sort of slowing down and they're really weak right now.
Mm-hmm.
Hence, when I fell, I couldn't stop myself.
Yeah.
Unfortunately, so yeah. But unfortunately, I had to make a very quick return from Vancouver, which is about 6 hours away from me where I am in the interior of BC. And we had a forest fire just 20 kilometers away from our house. So we had to zip to get ready to maybe evacuate. So BC is kind of on fire right now. It's been a hot, dry summer.
Sorry to hear that.
Yeah.
Every acre that burns is full of little bugs. I mean, all the little bugs that got their life ended. I feel sorry.
Wildlife is all displaced, bears and deer and this and that, and no, it's never a good thing. It's part of nature, unfortunately, but yeah, it's tough when it gets close to our homes.
That's right.
Yeah. So far so good. No evacuations, but we'll see where it goes.
Thank you, Sean, for that report. Gabriella.
Yeah, sorry guys, it's me again. I was just wondering if there's and I'm not sure if this question is allowed or not, but here we go. Is anyone here taking DNL 343 by any chance? No.
That was the for G, which one? That was red for healing.
I'm sorry, Sean, I wasn't able to follow what you said.
The DNL 343, wasn't that the Healy Regiment G?
Yes, that's
Yeah.
correct. I was just wondering if there's anyone here that is in that platform trial. Okay. Any news on predopidine? Like, is it going to get fast-tracked? Does anyone know?
I don't think that hearing has happened yet. So
Hasn't happened yet.
right, it's coming in the next few months from what we know of just what they've disclosed.
Oh,
And last question for now. Any news on stem cell treatment?
We had a presentation from RAPA about their open label extension, and that's a T-cell therapy. We have not had any other stem cell presentations recently, but we can certainly follow up with you, Gabrielle, and talk about what other ones you'd like to make sure that we're doing outreach to.
I was just wondering if anyone is seeing any positive signals from it.
Yeah.
Thank you.
Can I ask who asked about the ventilator installation on their wheelchair so I can get back to you?
That was Eric Brown.
Eric Brown. All right, Eric.
Hi, my name is Ines Robo, and I have my ventilator attached to my chair. It was something. I have the Astra 150, and they provided a package to attach to my wheelchair.
That's what we wanted to hear.
I'm sorry, it took a long time. I'm using my iPhone, and I didn't know how to unmute. Sorry.
That's okay. Thank you for being here with us.
Yes,
And
absolutely. Thank you for that.
Eric says okay. Cynthia, you have me guessing about all of these pins in the back of you. Does that have anything to do with us?
Oh no, that's just a large map that I have. It doesn't have anything to do with everything ALS. That's just my map.
Oh, well, it's cool to have a map like that, to be looking to see just how big this world is.
I know
where
I am in the world.
Yeah. Wonderful. Folks, it's what entertains us in our life. And I hope that the cure is entertaining somebody's mind right now, and they're going to spill it. So until then, Patty Hancock, good to see you, Patty. It's amazing. Yes. Our friend Patty and Jim.
My hand is so good. Will I have the symptom? No.
Oh, you do?
On the hand. And this one is kind of awkward. My left one used to be worse than this one. It seems to be better now.
Yes, thank you. That's what we wanted to hear.
Wonderful news.
Yeah, every
That's
inch.
really exciting.
Yeah, very good.
You know, Patty uses sign language, and it's really a cool. I mean, if you could only learn one word, like "I love you" or something like that.
You know what you need, McFinn? The alphabet, A through Z. Just 26 letters. And people like me can say whatever we want.
What a skill.
Jim is on lesson 52. He's learning from me.
Oh, beautiful. Patty had I'm not sure of the exact procedure done, but it was to help her hand, and that procedure is helping. So, folks, there is hope, and it's out there every day. Actually, it's just us connecting, and that's why we're all here together. Is because maybe you connected with something that's going to help us connect. It truly is an extended family. You're not going to find anybody who has something more in common than you do with ALS. This is a train that we're on, and it's not going to make a stop until we get to the cure. So let's everybody be on the train, and we're going to hear a song about that train one day. Somebody's going to write that song, and Willard's going to sing it for us.
Yeah, Willard, you got any train songs?
I think I do. I have one in the bag somewhere. Actually, I think Kathleen will be sending it to you at some point.
Yeah. We'll see if we can get that listed for you on Spotify or something so we can share it with everybody.
Oh, that would be great. Yeah, and hopefully we'll garner more attention, all the attention we can use.
Absolutely.
Can I show you something else cool?
Oh, Patty.
It's very light.
Oh, awesome. Awesome.
Because I was getting scared to go out, but now that's easy. I put a mesh back on my bullier and I can get out again.
These are the little victories, folks, that are big.
Yeah.
So, it's up to us to always share what I've repeated it. I'll repeat it again. What didn't work? What worked? We are detectives, and because we want to be, because we want to get better. And so we want to keep looking for the little thing that's going to make our day just a little bit better. And we want to come here and share what we found.
But McFinn, this is private, right? This information is only for, it's not going to spill out, right?
Yeah.
Yes.
Okay, so I'm gonna share a little something that I shouldn't be doing, right? My husband shouldn't be doing, but anyway. So Dr. Bedlock talked about some products in his last video, and we decided to try L-carnitine and bases. And my pal seems to think that of everything he's taking, and he's taking a lot of stuff, those two products are the ones that are helping him the most. So Dr. Bedlock gave I guess 7 different products, right? One of them is for cancer treatment, the other one, anyways, I don't remember all of them. But what we could try, and we did, were L-carnitine and bases. And there, I said.
Well, thank you, because we need really brave people in this journey. We need people who want to step out of the box, and it's probably out of the box is where we're going to find what we're looking for.
Please don't share this.
And just so everyone knows,
It's okay.
Yeah, just so everyone knows, the way we work is we record these sessions. We record the main presentations and some of the Q&A, but we cut it off and edit out any of the community discussion that goes after. So that never makes it out to any public channels or anything. Sometimes we record simply for making sure that we answer questions. And if there's anything that becomes like a frequently asked question, that we can feed it into the app as like an AI kind of chat thing for frequently asked questions. But no, this is entirely private.
And with that, folks, you know, time goes by pretty quick. It already hit the dong. But you know what? We never end this show until we say how much we care for each other. And so I'm trying to learn. Oh, boy. Oh, I'm getting a little better.
There you go.
All right. So I'm sending this heart over to my buddy Brian Kelly. Brian, my heart is streaming to you, brother. I see you. There you got it. All right. Every inch counts. So, folks, pick out somebody who you want to say goodnight to.
Good night, Joey.
Good night.
Good night.
Thank you, everybody.
Patty,
Thank you so much.
Cynthia.
Thank you for sharing.
Good night, everybody.
Tony.
Good night. Good night, Willard.
Good night.
Good night, Eric.
Oh,
Good
night.
TD, where's your grandma? Yeah, where's grandma? Is she grandma right over there? Yeah, that's where grandma is. All right. Thank you for showing us. Oh, okay.
That's
my mom.
Oh, it's your mom.
Okay. Thank you, dear. What's your name?
Good night, Tom.
Right.
All right. What a pleasure. Please come next week and smile for us again. Makes us all feel good. Okay, Joey.
Night, Finn.
Hey,
All right.
everyone.
Elizabeth, Eric Brown, Monica, Steve, Chuck, and my friend Jubilant. I
Thank you, everybody.
always want to say goodnight to Jubilant. And Monica, it's always good to see that smile, dear. Thank you so much.
Thank
And
you.
Yeah. You make, you know, we each are an ingredient, and we got to have all of us to make that cake be delicious. And so I'm going to say one last thing, and that's Joey. If you live where I think you live, boy, are you in, you got it going on. What a beautiful view.
I think I'll move in with her. I like that view.
Yeah.
Well, you never know in this little journey who we might just get really close to.
That's right.
That's right. Okay, folks, we're going to press that button and say, see you soon. Look in the mirror, smile. That's right. And make those thoughts come alive.
See you later.
Have a great night.
All right. Thank you.
Thank you.
All right. Okay. There goes that button, I think.
Yeah.
One of the hardest things I do.